Okay. So I will present you the colorectal cancer screening in Poland, but first I will say some general things. So the problem globally in the world is really high because all over the world currently there are about 18 million people a year, and it will increase for sure because the population is aging. We are getting older and older, we live longer, so there will be more colorectal cancers in the future. And the lifetime risk is 5 to 6%, which means that every 20% from this room will have, or already had, or has currently colorectal cancer. So I can say that about 6, 7 people out of this room will have colorectal cancer. The risk is quite large, I can say. The main risk factor is age. So the risk of getting colorectal cancer increases by about 1% each 5 years after age of 50. So the more 5 years, the 1% higher the risk. So what can we do not to die from colorectal cancer? We have 3 pillars. One is primary prevention, which is, as you know, healthy food, physical activity, not smoking, and so on. The secondary prevention, which is screening that we are talking about, and also tertiary prevention, which is the surveillance in people who have high risk, like a hereditary risk or had cancer before, and we have to make a control endoscopies. So the topic is screening. And screening, we should remember well, what does it mean? It means that we test asymptomatic people or without knowing the symptoms to look for cancer or adenomatous polyps. And in other screenings, usually they look for early cancer. But in this case, as Chris Milder told us, the aim of screening is also to find and remove adenomatous polyp or very early cancers. So if someone is going to start with screening in the country, there have to be decisions. First, which population to be screened? The whole country, or the region, or some areas. The second is to decide whether you want to have a population screening with invitations by letter, like in Netherlands, or just opportunistic screening, which means that people by themselves decide to go for screening, and you do that only for those who say, I want that. Okay, so this decision has to be done upfront. Then you have to decide the age limits. It can be that one, as usually in the world, 50 to 75, or you can have it 55 to 65, or you can choose a birth cohort, like 55 years birth cohort, or 60 age birth cohort, and concentrate each year on a single birth cohort. So you can have a freedom to do it because you cannot do screening for everybody from the beginning. So you have to choose some population. Then, of course, you have to choose the method of screening. It can be stool test or the primary endoscopy. You have to decide about the intervals. For colonoscopy is 10 years. For FIT testing is every 1 year or every 2 years. Then you have to decide, as in the Netherlands, about the cutoff value if you decide for FIT screening. So it has to be adjusted to the possibilities of the country to perform testing and also the ability to have endoscopy and so on. If you have a very low ability of performing large amount of colonoscopy, you set the cutoff value for FIT very high. So very, very positive results will only have colonoscopy. But if you have a lot of colonoscopies, you can go down with the cutoff value, of course. And of course, you have to, from the beginning, start about the quality assurance. So how to organize controlling the quality, because the quality is the critical issue in screening. So we are looking for effectiveness, and effectiveness is measured by reduction of mortality and reduction of incidence in the area that we are interested in. And this depends on compliance to screening, on quality of screening, depends on efficacy of the method chosen, and on the treatment. But the most important thing to measure is mortality reduction in the country, how the mortality decreases over the years. And we know from previous papers, generally, that mortality is decreased by FOBT screening by about 16% for those who you send the invitation. So the intention to treat analysis. Sigmoidoscopy reduces mortality by about 28%. With colonoscopy, we don't know yet because there are no randomized controlled trials published yet, but we are on the way going to have this in the future. So this value will give you how much you can obtain the mortality reduction. The other way of looking at this is the number of cancer cases prevented. This is for 1,000 people screened. If you screen 1,000 people, how many cancer cases you prevent? And this is the recent calculation, depending on the risk of cancer of the individual people. So if you have a population with 5% cancer risk, you prevent about 20 cases of cancer out of 1,000 people screened doing colonoscopy, or sigmoidoscopy, it will be about 15 people. With FIT screening, it will be about, let's say, 8 people. And with FIT every 2 years, it will be about 3-4 people, cases per 1,000 screened. And this is important to know. Of course, the efficacy is the highest for colonoscopy, but the compliance to colonoscopy is the lowest. So the lowest number of people will accept colonoscopy as a method of screening. And there are different approaches to screening. The American approach is to give the choice. Americans talk to the patient and say, you can choose between colonoscopy or annual FIT testing. If not, if it doesn't accept, they propose the other methods, like a CT colonography or DNA testing or sigmoidoscopy. If not accepted, then capsule endoscopy. So the American approach is to give the choice to the patient or to the organizers of the screening. European approach is that each country decides for the whole country. For example, in France, there was a decision to do the FOBT testing, or in Finland, or in UK. In countries like Netherlands, it's red triangles. As you can see, the decision was to do FIT testing. And it's true for the whole country. It's not a choice, but it's a decision for the whole country. It's an European approach. And colonoscopy in Germany, Poland, Austria is the method of choice for the whole country as an organized system. And there is an Asian approach, which is generally in many Asian countries, that GPs, the primary physicians, perform a questionnaire of the people, looking at the age, sex, family history, smoking, and so on, and they decide whether a given person has a high risk or low risk of colorectal cancer. If there is a high risk of colorectal cancer, they propose colonoscopy. If there is a low risk or moderate risk, they suggest performing FIT testing. Okay, so this is the Asian approach to screening as a whole system with a questionnaire first. And you have, because you are going to start, you have a great choice. You can choose whatever you wish is best for your country. And also, you need to remember that there are negative sides of screening as well. There are harms of screening. And these are the false positive and false negative results. If you give a false positive result, the patient will have unnecessary colonoscopy. If it's false negative, the patient will think he is healthy, but he has a cancer. It may happen, and the patient should know that and should accept this possible scenario. There are complications of screening, of endoscopy, of surgery, and the patients have to know that as well. There is also a harm that is currently investigated, is the overdiagnosis. Overdiagnosis is the situation that patients, that screening will detect the disease that would never become clinically symptomatic, would never become important for the patient. And because this, the patient will have unnecessary treatment. It may happen that the lesion detected would never kill patient, would never cause any problem. The patient will die of anything else. And we unnecessarily overdiagnose this person, and in this thing we are doing harm. This is the case, for example, for prostate screening, that there is a lot of overdiagnosis in the prostate screening. And also we should know that explaining the people that they are at risk of colorectal cancer, we are causing anxiety. The people get nervous, get frustrated, get afraid, and this is the negative side of screening. And also there are possible changes of lifestyle. This is a very strange harm of screening that was observed in Scandinavia, that people who underwent FOBT screening, stool testing screening, that thought that they are safe, and they started to change lifestyle. They say, okay, I had screening, so I can drink, I can smoke, I can be obese, doesn't matter, because I had screening, so I am safe. So why should I stop smoking? So that's also the possible scenario, negative scenario of screening. But let's say some words about the screening in Poland. We have different way. We decided what to do 19 years ago, in the year 2000. And because the organization in Poland as a country was very poor, we are not very well organized country. This was the main argument that we cannot organize a two-step screening, like FOBT screening first, sending invitations, then looking for the positive cases and asking positive cases to come for colonoscopy and so on. This would be too difficult for our administration. We are not good organizers just. So the simplest way was to do just colonoscopy for those who want. So we set up opportunistic colonoscopy screening in the beginning. And we performed primary colonoscopy on those who were referred by private GPs or by other doctors. So we built a lot of centers, we trained endoscopists, we introduced quality control, we had a national database of this opportunistic screening, and we trained endoscopists. But we realized that the better way of doing screening is the population-based screening with invitations. So we introduced invitations to colonoscopy in the year 2012. So these two systems, opportunistic and population-based, were in parallel existing, and now they exist in Poland. So we sent invitations to colonoscopy, and we used the online national database for all cases. And having this national database, we are able to perform a lot of research, looking of the different aspects of quality, mainly. So this is our structure. These are the numbers of centers. We are now 120 centers all over Poland. We had in the beginning 60 doctors doing colonoscopy. Now it's 570. A number of colonoscopies per year. Now it's 120,000 screening colonoscopies per year. There are also diagnostic colonoscopies, about 800,000. So altogether, we perform roughly about 900,000 colonoscopies per year in the whole country. In those, there is 100,000 roughly of screening colonoscopies. The coverage is not full, so not in all the regions you have screening colonoscopy, because the people are invited to the places where there is a closest to their living. So there are white spots where there is no screening available yet, but we are developing. Geographically, we can say 50% of the geographic area is covered with screening. In the part of the screening program, when we have sent invitations, the compliance is low. It's less than 20%. Although there are differences between the regions, the compliance is low. So only 16% of people accept letter invitations saying that we invite you to colonoscopy. In the first years of that, it was higher. It was 34%, but now it's decreased to about 60%. Having this database, we published some New England Journal papers, 2 of them. One of those was very important, to set up the adenoma detection rate as the quality indicator. And it says that the higher adenoma detection rate of the endoscopist, the lower risk of getting interval cancer by people examined by this doctor. So if someone is examined by doctors with adenoma detection rate about 20%, the risk of getting cancer is only 1 after 5 years. And it's much higher for those who have lower quality. So adenoma detection rate is a quality indicator that was validated in our Polish database. And we were trying over the years to improve the adenoma detection rate. This is the mean adenoma detection rate for the whole country. Currently is about 30%, 30. We also have performed a randomized controlled trial comparing teaching is TCL, versus just feedback, because we send back to our endoscopist what information, what is your adenoma detection rate. And people, endoscopists in Poland, know what is their adenoma detection rate from our database. So we compared how much we can achieve with teaching colonoscopy. There are 2-day course intended to improve the colonoscopy skills by the colonoscopist. And as you can see, after teaching in 2011 versus feedback information, the adenoma detection rate has not improved so much over next 2 years in those who only were informed about the adenoma detection rate. And in comparison, in those who were for 2-day training in our center, they improved substantially over 2 years, and this improvement was kept for a longer time as compared to control only. Also, if we increase the adenoma detection rate from baseline values, this means the decreased risk of colorectal cancer death. So improving adenoma detection rate decreases the risk of having cancer by 50%. So it's not only about doing colonoscopy, but doing a high quality colonoscopy, then you have you make your role. It's not about doing just a poor quality colonoscopy. It must be high quality colonoscopy. We also participate in the Nordic trial, that is randomized controlled trial to prove the reduction of mortality after screening colonoscopy. And we have given the largest number of participants recruited for this study. And these are the data for cecal intubation rate between doctors in Poland, Netherlands, Norway, and Sweden. And this is the adenoma detection rate for these doctors. And you can see the Polish doctors are quite in the top among these countries. It is also important to constantly monitor the outcome of screening. And this is our based on our invitational population-based screening, we included the monitoring system during the implementation of screening. So we randomize people to have the screening immediately after we invite, and also those who are postponed for 5 years. So some people, because we are not able to do it immediately to everybody, so we randomize them to have colonoscopy now or 5 years later to have the comparison and to find out what is the optimal age of screening, and we will know this information later on. Our 5-year survival is improving over the years, although it is not that high as in Netherlands, but it's in the range of 50%. But we started from the 25% in the 90s was the 5-year survival rate. So now it's improving, and it's a constant improvement, and we hope we reach Netherlands in the next 10 or 15 years, maybe. And our mortality has to be all the time monitored, and we can observe, and this is probably the effect of screening as well, that colorectal cancer mortality, as you see, was growing because of the aging population. But now we can say that we a little bit stopped this growth. At least it is now, the increase is stopped. I cannot say it's really decreasing, but it has stopped. So it has some population effect already. So in fact, in Poland, we have now long-term experience. We have a national database. We have all the data from screening from all people that participated there. We have a quality assurance of colonoscopy on the high level. We are monitoring implementation of the program. We are able, due to this database, to do a lot of research on screening methodology, and of course, increase in coverage and compliance is needed. And just for you, we are performing now the randomized trial, and we are thinking about introducing fit testing into our system. So we randomized people to 3 groups. One is, as currently, invitation to colonoscopy. The second group will be given choice between colonoscopy and fit testing. And the third group will be invitation to colonoscopy. If refused, we will send fit testing. So after this study, we will know whether the addition of fit testing to colonoscopy program will improve participation, because the current participation is not satisfactory. Thank you very much.